Hello, and welcome to our Impact with Aegis series. This month, our topic is IDDSI, a clinical guide to providing enjoyable foods for individuals with dysphagia. My name is Shyla, and I'll be your host for today. Before I introduce you to your presenters, I'd like to go over a few housekeeping items before we begin. First off, please note that all lines are on mute. If you have any questions or comments, please use the question feature on your taskbar to send those in. We will have a question and answer session after the presentation, so we can hopefully go over all of your questions and get those answered. Please make sure you have used your own unique identifying login so we have record of your attendance. If you are sharing a screen with someone, please note their name and email in the questions feature so we have record of their attendance as well. This webinar is offered at one ASHA CEU, although PT and OT are welcome to listen for informational purposes. If you look in your handout section, there's an ASHA participant form as well as the brochure and handout for the presentation. As a reminder, in order to receive credit, you must send that back to me. My email is shyla.hamrick, that's SHYLA .Hamrick, HAMRICK, at aegistherapies.com. You have to send that within 1 week. Please allow me 2 weeks to get certificates out. With nothing further, I will turn it over to our presenters, Bailey Gist and Allie Blaine.
All right. Hi, guys. Today, we're excited to present this course to you. I'll introduce myself. I am Bailey Gist. I am a graduate of Alabama in Montevallo, and I have been an SLP for about 3 years now. I have experience across the lifespan. I've worked in pediatric long-term care, outpatient schools, acute care, and skilled nursing facilities. I have a special interest in dysphagia and accessible instrumental swallowing assessments, as well as dementia and neurocognitive disorders. And I have been with Aegis Therapies as an SLP, as a therapy coordinator, a director of rehab, and currently as a regional clinical director.
Hi there, my name is Allie Blaine. I'm a speech language pathologist. I have been in the field for almost 3 years. I graduated from Texas State University with my bachelor's and my master's degree. I specialize in providing services to the geriatric population in skilled nursing rehab and long-term care facilities. My special interests range from dysphagia and interpreting MBSSs to providing socialization opportunities, comfort, and environmental adaptations to those with dementia, aphasia, and voice impairment and Parkinson's disease. I am AmpCare Effective Swallowing Protocol certified and Parkinson's Voice Project Speak Out certified. I have worked with Aegis Therapies as an SLP and clinical catalyst, and I'm dedicated to achieving superior patient outcomes in long-term and inpatient care by actively participating in communication and collaboration to meet everyone's wants and needs.
All right, Allie and I are both employed by Aegis Therapies, and we do not have any conflicts of interest with this presentation. This presentation is not a direct affiliation or endorsement from IDDSI and is just meant to provide education on the IDDSI initiative and guide through potential challenges based on our experiences. The education shared is not meant to replace the materials and resources that are housed on IDDSI.org.
The learning objectives of this course aim for the attendees to be able to summarize the IDDSI initiative and to identify the various consistencies within the framework, to be able to define elements of a streamlined SLP evaluation and demonstrate how to prepare with the interdisciplinary team to transition to the IDDSI framework, and finally to be able to apply tactics to overcome challenges to have a successful transition. We will be asking a few polling questions throughout the course. That said, here is our first polling question. Is your workplace implementing the IDDSI framework currently?
Okay, we'll go ahead and close that poll. 8 of you said we are in the beginning phase but have not rolled out yet. 10% says we are offering one or more elements but not all. 20% of you said we have fully transitioned into the IDDSI framework. 41% says we have not started implementing, but I am familiar with it. And 21% says we haven't started implementing and I'm not familiar with it.
All right, thank you guys. So some background on the IDDSI initiative. So discussion began in 2013 and they ultimately published the initiative in 2015 with a goal of standardizing diet consistencies and the terminology that's used so that you could implement it across any care setting and any culture. So the mission statement is to facilitate the safe consumption and enjoyment of food and drink by all persons with eating and drinking difficulties or dysphagia by maintaining the IDDSI framework, a common knowledge and system of practical and valid measurement techniques for naming and describing food texture and drink thickness, continuing to provide free access to the IDDSI framework, documents, and electronic resources, and fostering global implementation and use of IDDSI. So we'll start by taking a look at the framework. So you can see here that for each level, we have a name, we have the number associated, and there's a color associated so that it can be easily identified across the span of knowledge, ability to read, ability to see color, things like that. There is a pyramid for foods and a pyramid for drinks, but you will see some crossover here where pureed food would be the same as extremely thick drink. And then liquidized food would be the same as a moderately thick drink. So we'll continue to go further into this, but this is just a quick glance at some things that you may see out there that would identify the IDDSI framework.
It's important to note the change in terminology that IDDSI has done to take further efforts into dignifying individuals with dysphagia. As you just saw on the IDDSI framework, items are now referred to as food and drink, whereas previously we often said solids and liquids. National Dysphagia Diet, or the NDD levels, include thin, nectar thick, honey thick, and pudding thick liquids. And dysphagia purees level 1, dysphagia mechanically altered level 2, dysphagia advanced level 3, and regular solids. Now, NDD and IDDSI do share similar attributes. They were both created to provide various consistencies or textures to meet the needs of individuals with dysphagia. As you can see, IDDSI level 4 extremely thick is compared to NDD spoon or pudding thick. IDDSI level 3 moderately thick is compared to NDD honey thick. And level 2 mildly thick is compared to NDD nectar thick. IDDSI level 1 slightly thick is an additional option provided that is not present in NDD. The differences of these two protocols go into further detail. The structure of NDD is generalized, subjective, and undefined, whereas the IDDSI framework is specific for each consistency and provides objective measures of food and drinks. There are limited evaluation tools for modified food and liquids on NDD, and IDDSI framework provides standardized testing methods and tools for evaluation of modified food and drinks. Pureed is a consistency and name in both IDDSI and NDD, although IDDSI level 4 provides more objective measurements and tests, which we will discuss later. NDD mechanical soft is like the IDDSI mince and moist, but IDDSI framework includes descriptors of consistency, standardized measurements of the size of food pieces, and explains the necessity for food to include added moisture to decrease the risk of unsafe swallowing. It's also important to note that there has been a shift from focusing only on the meats to also the sides. Even the preparation of sides is clearly described and differ between each consistency, which was not really clarified before. NDD dysphagia advanced was intended to provide bite-sized pieces of food, but the pieces were often cut bigger than the trachea size. IDDSI level 6, soft and bite-sized, considers the average size of adults and child tracheas and mandates that food is cut into standardized size pieces with that consideration.
All right, so a little about the testing. So starting with testing of drinks. While some prepackaged drinks may be labeled, there's times that they're not. So an Ensure is something that is prepackaged and we commonly give to patients and residents, but it's not labeled with a consistency. So it would be important that we're able to complete a test to guarantee that you know what it is and is not appropriate for each consistency. So IDDSI does have those standardized tests built in, and the testing for drinks would be a flow test typically. Remember that a temperature of a drink can change the consistency over time. So if that drink has sat out, it may be thicker than it originally started. So we would want to be able to quickly test that drink at any moment in time and know that that would still be appropriate for the patient or not. When we're manually thickening drinks, we want to be able to test and know that it's been thickened to the appropriate consistency and that it's reliable across multiple people. The IDDSI flow test, it takes about a minute. So from setup to completion, it shouldn't take you a whole minute. And it allows for accessible, reliable, and simple testing that anyone can complete. So we can teach this to other healthcare professionals. We can teach it to family members, and we can even teach it to our patients so that they can complete that and know and feel confident that that is the safe texture for their loved one. IDDSI level 4 extremely thick drink does need to be tested via a spoon tilt or a fork drip test. So the IDDSI flow test, what you will need is a 10 milliliter syringe with the plunger taken out, a timer, and the drink being tested. It's important that the syringe is 10 milliliters in size and not larger, and that it's also 61.5 millimeters in length. So you can purchase them this way. What you will do is you'll cover the nozzle, so that bottom piece, with your finger and fill the syringe to 10 milliliters. You'll then set your timer and release the nozzle, letting the drink flow for 10 seconds. After 10 seconds, place your finger back on the nozzle and check for the amount of drink left in the syringe. The visual on the right shows you based on how much is left. So looking at 4 milliliters to 8 milliliters, that would fall within that IDDSI level 2 mildly thick consistency, and that would be appropriate for them. You will still see that 10 milliliters left would possibly be level 4, but we would also want to validate that with the fork drip or spoon tilt test. For testing of food, there are 8 ways to do this. You can use a fork drip for levels 3 and 4. You can use a spoon tilt for levels 4 and 5. You can use a fork or spoon pressure for levels 5 and 6. You can also use the chopstick and the finger test for levels 5 and 6. The fork or spoon separation test would be used for level 6, potentially for level 7 easy to chew foods. And then the transitional food testing is available as well. So the fork drip test can be used with IDDSI's level 3 and 4 again. To make sure that we're compliant with those texture guidelines, we want to refer to the descriptions of each, which you can find on IDDSI.org. The spoon tilt would be used with IDDSI's level 4 and 5 and is designed to test the stickiness and the cohesiveness of the sample. So is it really going to stick when it goes down the throat? And then is it able to hold a cohesive bolus or not fall apart and piecemeal? The sample should hold its shape on the spoon and be able to slide off with only turning the spoon or a gentle flip of the wrist with only a film left at the most. So looking at the visual, we can see here, this looks maybe like some yogurt, and it's able to easily come off of the spoon, and that would be appropriate. And it holds its general bolus shape. Then you see the peanut butter on the right, and it's going to take a lot of effort to get that off of the spoon, and there's still a lot left on the spoon. So that would no longer be appropriate for this level. And then you see a visual as well at the bottom left side of the fork drip test. And what you're looking for is that for moderately thick or liquidized, that drips slowly through the tines of the fork, but it is not pouring through and it is not heaping on top.
Okay, the pressure tests can also be easily completed in any setting to ensure appropriate consistency of food. The fork pressure test allows for testing of size and firmness of foods. The standard fork is about 1.5 centimeters wide, and the distance between each tine is about 4 millimeters. IDDSI level 5 minced and moist food particles should fit between the tines of a fork, be no longer than 15 millimeters or 1.5 centimeters, must be soft enough to smash without blanching your fingernail, and should pass the spoon tilt test as described in the previous slide. IDDSI level 6 soft and bite-sized food pieces should be about 15 millimeters or 1.5 centimeter squares. Remember the average width of a standard fork here. And it must also be able to be smashed with enough pressure until blanching is observed on your thumbnail without returning to its original shape when releasing the fork. The spoon pressure tests also test firmness of foods. Just like the fork test, the thumbnail should not be blanched on minced and moist and should be blanched on soft and bite-sized. This technique is used because IDDSI reports that it is the same as the average tongue pressure during swallowing, which is about 17 kilopascals, which is a pressure measurement. IDDSI has also included directions for testing with chopsticks and/or fingers for all foods to recognize that these methods may be more accessible in certain areas, which would be utilized just like the fork and the spoon. The separation test with any utensil is used with soft and bite-sized and easy to chew to ensure the food can easily break apart. Transitional foods, which are typically appropriate for levels 5 and 7 through 7, supplemented with SLP evaluation, are foods that start as one texture and change as moisture or change in temperature is applied. For example, a Cheeto Puff or a thin potato chip are often transitional foods. Testing consists of using a sample about the size of a thumbnail, placing 1 milliliter of water on the sample and waiting 1 minute. Then applying fork pressure and ensuring that the sample is squashed and no longer in its original shape. It can be easily broken apart with chopsticks, breaks apart and remains apart when rubbed between the thumb and the index finger, or is completely melted. All right, now preparing for implementation of IDDSI. Think of this guide: monitor, aware, prepare, adopt. IDDSI ensures continuously monitoring every step of implementation, building awareness across facilities to all impacted clinicians, professionals, administrators, supply chain, and others, all support staff, to communicate who, what, where, when, why, and how all is impacted. Next, they prepare by accessing processes and protocols that may need to change, approving changes, preparing materials, inventory, etc., and to train clinicians and all staff involved. Lastly, adopting the framework to introduce the IDDSI system for ready-to-use goods at the facility level and within food service, all to gain success with transition and integration. The SLP's role is integral for a successful transition in your community. If your workplace has not yet developed a plan for implementation and you see potential for your community, you will advocate for this yourself with the support of your DOR or supervisor. You will communicate with the interdisciplinary team, which may include the administrator, regional directors, director of nursing, director of rehab, dietary manager, and others about preparation, the roles of each team member, and establishment of a rollout date. I just want to make note that sometimes the company of your facility will establish it for you at the start of the transition, in which often the SLP will lead within the community. You will be an active listener when asking for feedback regarding any concerns so that you can address within your scope of practice. You will evaluate individuals that may need a diet change or that will be impacted by the change in framework or terminology. To streamline, you must prioritize the diet comparison and severity of patients' dysphagia. For example, my facility only initiated the transition by first including level 6 soft and bite-sized. And at my facility, this would have compared to the mechanical soft and the mechanical soft ground. Patients who were on regular and chopped, which there is a lot of discrepancy there, which at my facility was a regular diet with only chopped meats, those would remain the same. I collaborated with my director to create schedules that would provide ample allotted time to conduct thorough evaluations. Potentially further extensive intervention based on the interpretation of the evaluation may not be needed, although screening should be conducted routinely and as needed. You also provide ongoing in-services and training, especially with kitchen and nursing staff, to ensure consistency of implementation and carryover. Carryover of training is achieved by establishing an open line of communication so that team members can ask you guidance of any confusion or concerns that they're seeing after beginning implementation, during, and even after it has been established.
All right, so potential challenges that may be faced, and again, these are based off of our experience and how we would suggest overcoming those. So we'll open here with a polling question. So what is your biggest challenge or anticipated challenge in implementing IDDSI framework? Please note to select all that apply.
Okay, we'll go ahead and close the poll. 25% of you said lack of staffing and or high rates of turnover. 27% said lack of and or minimal knowledge regarding the framework. 4% said concerns with patient satisfaction, and 44% of you said concerns with consistency of follow through.
Okay. So first we'll address the staffing concerns or high rates of turnover. So as IDDSI implementation continues to grow and become more widespread, more staff members are going to enter your workplace with background knowledge of this or experience with this framework. So again, this is something that the initiative is to implement it across internationally. So other nations would have it, any other care setting. So it's meant to be this common knowledge. So while we're still in this learning phase in a lot of places, as it continues to grow, you will see that others come in and they already have some knowledge about this. And so they're able to jump in a little more quickly, and you may not have to train someone over and over from the beginning. The testing methods that they have built in are intended to be accessible and user-friendly. So you can teach them to anyone very quickly. So you saw the food testing and you saw the drinks. They're very simple and quick, easy to learn. So this would allow you to teach others to how to test foods and drinks in an easy way, something that doesn't require a lot of time commitment or a lot of base knowledge to learn. Another thing that you could do is keep a reference binder easily accessible to all team members. So maybe that's at the nurse's station, maybe that's somewhere in the dining room, anywhere where that is allowable to have. And then the team member could quickly reference the guides. And these are already housed on the IDDSI website, so you don't have to create these from scratch. But you could write on any special considerations that maybe your community is implementing that aren't part of this standard protocol. So having this for people to reference back can be really key when you have that high rate of turnover and you've always got someone new in your community. It's important to establish a line of communication and trust so everyone knows that you can be reached with questions, but you don't want to have to take on all of that all the time because you're not there. So it could be useful to have a leader in each department that would be the expert for any questions asked within that department or within that time frame. So maybe you have a nursing leader on day shift and night shift. Same for dietary. Same for just your CNAs versus your nurses. Same for your therapy staff that may have questions. So there's multiple people that take ownership in this and can help you with the communication.
As this is still a new and potentially unfamiliar transition for many of us, we all will have gaps in knowledge and the opportunity to learn more. The IDDSI website is free for anybody to access and it contains an abundance of resources to guide implementation planning, provide education to staff and family, and to better edify our research in supporting the initiative. Resources are included, but not limited to clinicians, other healthcare providers, food service and catering, and family. I encourage all of you to go to idsi.org/resources. It's really endless of what you would like to find in order to implement this in your building. The true buy-in is the patient satisfaction with the IDDSI framework. It provides opportunity for individuals to have a truly individualized diet, including making exceptions based on clinical judgment and with standardized testing measures, and for the individuals consuming the diet to recognize their meals as they are more consistently prepared. With the increase in options, they become more appropriate and less restrictive for individuals that were once only under mechanical soft or mechanically altered or pureed. Consider how some individuals are limited or restricted to puree, but may be able to appropriately consume minced and moist, or individuals who are limited to a ground or shredded meat under the mechanically altered, but may be able to safely consume soft bites of meat, like the soft and bite-sized. As noted earlier, consistency of carryover is imperative. Providing in-service and trainings is an ongoing protocol. This may include keeping handouts printed in color with photo examples, as that will be more appealing and will maintain others' attention, and those can be prepared as needed. You may provide a laminated copy or binder for specific areas, including maybe the kitchen, in front of the kitchen door, and at each nurse's station for easy access to reference. Finding times where training can be done in groups, planning a scheduled meeting with the kitchen staff, which may include showing a quick video example and reviewing the prepared handouts. Or maybe you could attend the morning meetings and/or the routine nurse and CNA meetings during shift change, so that you're able to provide this education to several people at once, who then will be able to carry over that education into the next shift change. SLPs can also test trays made in the kitchen frequently and as appropriate for your community. Maybe this starts doing weekly with initial implementation, and then maybe you'll do it monthly and then transitioning to quarterly testing of trays. I would encourage those designated leaders who have been a part of the initiation and transition, which may include, like Bailey had said, maybe a morning nurse and a night shift nurse, the DON and the assistant DON, the dietitian and the dietary manager, all can participate during tray testing. This provides an opportunity for several people to understand through examples and to then provide carryover to other staff and caregivers.
All right. So like we said earlier, the IDDSI website really is a wealth of knowledge, and that is the only reference that we use for this presentation. So I think that it can show you just how much there is out there. So we encourage you all to go dig into the IDDSI website after this and get some more information. All right, now we'll open it up. If anybody has any questions, please put them in the chat box and we'll be happy to answer.
Okay, our facility is NDD, the acute feeder hospital is IDDSI. What can you recommend for admitting nurses who transcribe orders?
Yeah, Allie, would you like to answer that, or would you like me to go for it?
I can answer that. We've had that often too, as currently at our facility, we don't have the minced and moist, and I get a lot of those hospital admissions with minced and moist. I would, through all of this education and training with the nursing staff, I would encourage them to make sure they are understanding what that diet looks like. So when you're providing your in-service and training of IDDSI, they'll have a baseline understanding of it. And then it would be integral if they felt comfortable, potentially if you provide with the NDD, if you have the mechanically altered where they are providing more of a ground meat. That could potentially be a similar transition or terminology, or potentially they may have to put them on puree until an SLP can come and evaluate to confirm. If they do decide to do the mechanically altered, I think it would be of note to always add that there be extra sauces or gravy, as that's not included in the NDD. That is kind of a big part with all of the modified diets in IDDSI. So that could kind of be a thumb of rule that they are adding that gravy and sauce, because we know that really helps with the swallowing function and just making it slick to go down, if that makes sense.
Yeah, and I'll add, I think this is probably an opportunity for potential advocating for getting this IDDSI initiative started in your community. And if that is not an option, then I agree with everything Allie said, but remember that, you know, if their question is there, then it would be important for you as the SLP to get to that patient as soon as possible to provide that evaluation. But we can provide resources in the meantime of what would be, you know, maybe you build a pathway form. So what is the appropriate pathway if somebody comes in with this and it's questionable? Where do we go? And maybe you're part of that decision process up front until you're able to get in and evaluate the patient and really decide what that individual needs.
Awesome. What has been a realistic time frame for rolling out this diet?
Okay, so at my building, we have the company of my facility decided to roll out with one consistency. So we focused on rolling out one consistency, which was decided to be the soft and bite size. Realistically, I work in a community that is a 120 bed facility, often having a census of maybe 90. So when including new admissions and doing screenings of all of our long-term patients, it did take me about 4 to 5 months. And it was with that initial rollout from the company, they gave that grievance where you had before actually the diet being included under the drop-down menu, I would start already doing evaluations. Now, with that being said, that means you need to have the kitchen trained first, because they need to be able to provide that type of consistency so you can evaluate the patient. So it does take time. First, you want the kitchen to know how to make it. And even if it isn't officially rolled out, if they're at least making 2 or 3 of those trays a day, you can do those evaluations each day.
Yep, I agree. And I'll add that on the IDDSI website, there is a implementation guide that is specific for each discipline. So it's got a part for dietary, it's got a part for clinicians, and it rolls on about a 12-month plan. I think that it can vary per community on what this looks like for you. I personally implemented in about 6 months at my community, but 12 months I think is a fair amount of time to start from spreading that knowledge all the way through the initial implementation, and then remembering that there will still be follow-up for a good bit after launch day, because you'll want to make sure that it's consistently carried over.
Awesome. Any suggestions for a facility struggling to implement soft and bite-sized diets? I feel that they are trying to take regular texture foods and alter everything rather than picking foods that don't necessarily need to be mechanically altered and just be cooked to the correct softness, since they're already naturally the same size.
I can go ahead and start with that one as well. It is true. It may depend who your food service supplier is, but in collaborating with my dietary manager, who will be ordering all of the food, he was able to find so many different vegetables and meats that were already cut into those soft and bite size. A lot of the food suppliers are becoming familiar with IDDSI, so they are making those pre-made foods like that. Unfortunately, there will be times when they will have to cut it up, but the food service industry has definitely made improvement in already providing food that is already with that consistency.
what are your recommendations for approaching administration, dietary, etc., who are resistant to transitioning toward IDDSI?
I think a really big concern in the community is malnutrition and weight loss. If it's not already implemented, is discussing the weight losses frequently amongst whoever is a part of your weight loss management team. And that is a huge concern for everybody in the building, including the administrator. I would present with numbers of who may be under that realm of malnutrition and weight loss. And oftentimes you are also able to get information from the patient that they don't want to eat the food because of the way it looks or the way it was too modified or whatever it may be. And so then you can compare that to the options that IDDSI will provide and how that the food is more recognizable through these following the protocols of each diet, and that there is, a huge potential for there's going to be more patient satisfaction and that they will want to eat their food because it is more appropriately made for them.
Our SNF and ALF started with IDDSI, then went back to the basic diet levels, said too costly with the levels. I presented them with research, but the bottom line, they wanted to save money and make it simple again. Mad face. I mean, I don't know that that's a question, but if there's any feedback that you guys could give.
Yeah, I hate to hear that. I don't know if it's a matter of that they are, maybe the supplier that they're using is just having difficulty bringing things pre-prepared like that. And if there would be an instance where dietary staff could be trained on, where foods would need to be modified by them in the kitchen, and then where foods may not need to be modified. So minced and moist, for example, using that fork pressure test, it would pass if you can press it down without blanching your thumbnail and it fits between the fork tines. So like green beans that have been cooked down well, that's already going to fit. So it's not any extra labor. It's just a matter of cooking it. They don't actually have to grind that after. So that builds the patient satisfaction. And then it also cuts down on the work that's being done in the kitchen. So I'm really sorry to hear that. I don't know exactly what the root of the problem was there, but I would dig in a little more and try to figure out, what part of that was costly and see if you could problem solve through that.
I'd like to add a little bit to that, just with things being costly and wanting to buy things that are already prepared the way it should be. Like I had mentioned earlier, there are a lot of items that the kitchen aides and cooks will have to prepare. And I think where they've lost their buy-in is maybe they don't know that patient. Maybe they haven't gone out and met anybody. And that's where I would take that opportunity in building my relationship with the kitchen staff to encourage them to go meet the people that they're providing for. If they could talk with them a little bit more and just see their point of view and just knowing them as a person, I know that that helped my kitchen staff a lot after they started to do that. And now they want to go a little extra for them because they know who they are.
Great. Any suggestions for items or products facilities can buy in bulk that will already come in the correct size for soft and bite size? Kitchen says they're going to need to dice everything, but I don't believe that's true if we just look a bit harder to find the right products.
I'm personally not familiar with anything off the top of my head that's already prepared as soft and bite-sized. I'm not sure, Allie, if you've run across that.
I do. I think there are very few items right now. Off the top of my head, I can think of peaches that have been drained, no liquid, that are already diced. There's a lot of fruits that are going to meet that criteria. I think this is where the SLP will take liberty in finding food items that a patient can appropriately eat that may not necessarily be exactly to that protocol. For example, I have plenty of people who, love the oatmeal cream pies. And because of how it's prepared, if I know that there are certain food items that people like, we can go in and specifically provide those things. And then there's going to be collaboration with the dietitian and the dietary manager to all come to an agreement that that would be appropriate for that patient. I have not been able to find a lot of snacks that are already prepared the correct way.
Where can 10 milliliter syringes be purchased? From IDDSI website, Amazon?
Yeah, so I don't think the IDDSI website has any, but there is a thickener company called Simply Thick. Correct me if I'm wrong, Allie. But they do have the syringes already available, and they will send you a starter pack if you want to sign up on their website. Sometimes they do a free promo, other times it's $10 to get it. So they'll send you some of the syringes and then some of their thickener as well. And those syringes are actually already labeled, so that's an extra nice piece. You can also purchase from Amazon just those standard syringes, just making sure that it fits within those specifications. And then your facility may already have a vendor that they're using for other medical syringes that you could purchase a syringe through. But I personally do really like those Simply Thick syringes because they're already labeled for you and they come without the plunger. And then you also get some thickener along with that, as well as some cups that would be labeled for ounces. So you would know how many ounces you needed to put in there, and then how much thickener, and then you can test that with the syringe that's already labeled for you.
Yes, I completely agree with that. Simply Thick is a really cool website for that stuff as well. And maybe if you did have to buy a sample, your facility could help with that as well.
Okay. Another one's, let me reword that. I mean items for lunch and dinner that come frozen as the correct size, and then kitchen just needs to cook it to correct softness. Any products your culinary providers have found, like carrots that come in medallion shape or things like that.
Yes, I believe our food service provider is Cisco. So example, the carrots, they actually have they're cubed, but they're slightly smaller than the 1.5 by 1.5, which would still be appropriate and safe for those who are on the soft and bite size. But yeah, that's a perfect example right there. Those carrots are already in the perfect shape for that. There's also been we've had turkey that is already diced and following that protocol, and it's not larger than the 1.5 by 1.5 centimeter dimension. And so then all they have to do is cook it to its correct consistency and potentially then they will add a sauce or a gravy to coat.
All right, perfect. That is the last of the questions. I will give a second for any others that may come through. We have one comment, just says, not a question, but thanks. This was interesting. I like how it was more objective.
Thank you.
Thank you. And that was one of my personal buy-ins with implementing IDDSI. Is it's so hard with food to provide a black and white answer, which many of our kitchen staff want and our nursing staff. And I feel like with IDDSI, we are closer to giving that black and white answer of how to prepare things.
Is there a deadline of when facilities have to implement this?
There's not, to my knowledge. I do think that at this point, the dietary manuals typically only recognize IDDSI, but it doesn't necessarily mean that the NDD levels or any other diet levels can't still be used. I'm not aware of any deadline at this point that it's been made mandatory, but IDDSI does provide updates about that on their website if that were to happen.
Okay, well, I think that is it. With that being said, we will go ahead and close out this. I will let you guys know you have 1 week to submit your ASHA forms to me. I'll put that again. It's shyla.hamrick@aegistherapies.com. It's shyla.hamrick@aegistherapies.com. And your certificates will be sent within 2 weeks. But be sure to have your ASHA participant forms to me within 1 week. And with that said, we will end this webinar. Thank you, Allie. Thank you, Bailey.
Thank you.
Thanks, everyone.
Have a good evening, guys.